this is Roger Green, host of the Surfing International Tsunami podcast. This weekend, we are offering 6 conversations from episode 42, our review of last week's SLD Summit, plus from the vault, a conversation from what was called the NAFLD Summit back in 2022. This conversation centers on the research that Sven Francque and his colleagues presented at the SLD Summit. Most of their research focused on portal pressures in pre-cirrhotic patients, which exist sometimes even in patients with fibrosis levels as low as F0 or F1. Sven notes that while relatively few of these patients have elevations of 10 millimeters or more, which is what we normally consider the portal pressure boundary, a significant number of patients do have elevations from 5 to 9 millimeters of mercury, which might affect their health in more subtle ways. I ask about the impact of this work on how we treat patients today and in the future. Sven identifies several areas for future research that will help us answer that question better over time. As we move toward the end of this discussion, Louise Campbell asks a question about using NITs, notably VCTE, to check for pressures in these patients because some of her work, VCTE and biopsy and non-biopsy liver, showed different results. Sven congratulates Louise on the question, indicates this might be a powerful area for future research, and with this, our session with Sven comes to the end. The SLD Summit 2023 revealed some of the new energy and areas for research brought about by the nomenclature change and presented existing new concepts for basic science and drug development, all of which promises a very exciting future for liver researchers. These interviews with Sven Francque and Hagström capture some of the excitement in novel concepts, so just sit back, listen, learn, enjoy. When you're done, join the dialogue on our LinkedIn discussion group. Sven, what research did you share at the meeting?
Sven Francque.
We talked mainly about the vascular mechanisms. It's a long-standing interest of us. It's studying how changes in the endothelial function, not just endothelial, but the whole vascular biology of the liver is something that seems to occur already early in disease and probably contributes to disease evolution. And it's also for the whole spectrum. So it's also relevant once you get to the advanced stage of the disease and what we're still calling cirrhosis, where also the vascular mechanisms and the mechanisms of portal hypertension seem to be different in this disease if you compare it to alcoholic liver disease or viral liver disease. So we, in my talk, and also one of my co-workers had an invited talk, we mainly discussed those vascular mechanisms, and Professor Pierre-Emmanuel Rotou from Paris, Bourgeon, also discussed data, clinical data on early signs of capillarization of the liver sinusoids in patients with NAFLD NASH. So both the basic and the clinical data were covered, but we also presented some data on a cohort of our center with about 126 or 25 patients that had portal pressure measurements by HVPG from the whole spectrum, so not necessarily patients with cirrhosis, showing that even in patients that do not have cirrhosis, you have patients with elevated portal pressures, even in F0 to F1. Now, the portal pressure is...
Oh, really?
Yeah, portal pressure in these patients is only very rarely elevated above the 10 millimeters of mercury threshold for clinically significant portal hypertension. But they do have some degree of subclinical portal hypertension, meaning that there is an increase in their intrahepatic vascular resistance. And that is more pronounced once you get to the more advanced stage, but it's not restricted to patients with cirrhosis. And that is not just a sampling variability issue of the liver biopsy. We also looked into other parameters, and these patients clearly with elevated pressures, for one or two exceptions where based on imaging you could suspect a cirrhosis, but the other ones were clearly non-cirrhotic patients, also with other tools than just the liver biopsy.
So you said more frequent in F0 or F1 even, at the sub 10 millimeter level. What proportion of those patients exhibit signs of that at a sub 10 level?
Well, if you put them into two categories and you separate the cirrhotic ones from the non-cirrhotic ones, in the non-cirrhotic ones it's about 1 out of 3 that has an elevation of portal pressure. But as I said, very rarely it's above the threshold of 10 millimeters of mercury. So about 2/3 they have normal portal pressure and 1/3 has an elevated portal pressure. When you look at the cirrhotic population, of course, the vast majority has some elevation of portal pressure and quite a substantial number has clinically significant portal hypertension.
So let me ask my colleagues before I ask you. If you knew that an earlier stage fibrosis patient had elevated but not 10 millimeter elevated portal hypertension, would that change at all how you thought about treating that patient or advising that patient?
Jörn Schattenberg.
That's the next step. I find I found this data very interesting, Sven. I have to say, congratulations. It addresses some of the pathophysiology of the disease that we don't understand well. I think with potentially fat, alternating blood flow, capillary blood flow, is my understanding. Not sure what you think. It's not the same phenotype as we see in cirrhotics, because there the distortion of the liver tissue is, of course, something to a much bigger extent. But it could be a subgroup of patients that has a different prognosis or different treatment options, and that's where you're coming in, Roger. I would think, yes, this is something that should be corrected if it's pathophysiologically relevant to these patients. The question is, how do we assess this non-invasively? It brings us back to an old discussion in the MASLD field.
Yeah, I think Jörn is absolutely right. Diagnosing this clinically is for sure challenging. Personally, what I take from the research that we have been doing so far is that these mechanisms are probably contributing to disease evolution. And we should not forget that also, Roger, you talked about viral hepatitis, and we know that if you have viral eradication, there is a tremendous improvement and regression or even disappearance of fibrosis. But what has also been shown is that some aspects of alterations of the liver vasculature, like the capillarization of the endothelium, is something that tends to persist even if fibrosis regresses. So it's a kind of lesion that seems to be more resistant to regression in other diseases. It has not been studied so far in FLD space or the MASLD space. But we should be careful, because we've seen with tackling the metabolic drivers of the disease that you have a substantial, or you can have a substantial improvement. But not all patients respond, and especially when you have more advanced fibrosis. With the pure metabolic approach, you don't see any significant results on regression of fibrosis, probably less progression. So there is also a signal, I think, on fibrosis, but not very strong on regression of fibrosis. So we should really make sure that we are not overseeing changes that are probably not so reversible as some of the other aspects of the disease are. Another aspect, and it was touched upon a little bit by Arun Sanyal, who gave an excellent talk on the first day on NASH cirrhosis or MASH cirrhosis and the challenges we have. And he also tackled the aspect of vascular lesions in these patients. He even said that he tended to start thinking that MASH cirrhosis was a vascular liver disease, showing the importance of the vascular mechanism. But he also showed the data that has been gathered by groups where we also participated, that the portal pressure in, as I said already, the mechanism looks a little bit different, and there might be a pre-sinusoidal component to the portal hypertension, making HVPG even underestimating a little bit the real portal pressure in patients with cirrhosis, because we could document that for the same amount of elevation of portal pressure as measured by HVPG, you have a higher rate of decompensation and mainly ascites in patients with the MASH cirrhosis. And also a study in TIPS, but that was not a study where we participated, showed that there was some disagreement between HVPG measurement and direct portal pressure measurement at the moment of the placement of a TIPS in patients with MASH cirrhosis, which was not the case in patients with viral hepatitis-related cirrhosis or alcohol-related cirrhosis. Pointing again towards the fact that, and Jörn rightfully says, once you get to cirrhosis anyhow, there is an important distortion of the architecture, including the vascular architecture, but it does not seem to be completely the same in MASH cirrhosis compared to those classical sinusoidal portal hypertension etiologies.
So I understand that your graduate student researchers will have a lot of work to do in their careers. Yeah?
Absolutely. But I'm a little bit biased because it's my topic for many years.
Yeah, but it's an important topic.
It's a fascinating topic. Yeah.
Either of you folks have any questions, or first of all, Sven, as Jörn already said about your work, congratulations on a fantastic meeting, and I think really broadening the boundary, a program that broadened the boundaries.
Okay, thank you. Nice to hear that.
For future events, I thought that was fantastic. Jörn, Louise.
Louise Campbell.
I did have a question. Sven, have you done fasting, non-fasting FibroScans in that
population. The reason I ask that is we used to do a real-time FibroScan clinic and only bring the ones back who had elevated KPA. And when we reviewed them, the average movement in the KPAs was 4.5 kilopascals, and it was actually around 100 in the 1,000 patients. And the CAP score moved 0.08. But in some of those that we looked at who'd had the kilopascals shifted, where they'd had a biopsy, they only had sinusoidal changes. So it looked like the potential to detect that mild gradient shift with kilopascals, which is a pressure measurement. And as we know, the liver shouldn't stiffen up when we eat. The blood flow should still be nice and soft throughout the liver. But it's whether or not you can detect it in fasting, non-fasting, because you actually increase the blood flow and the peripheral resistance.
I must say, Louise, this is an excellent idea that you bring up. We didn't check that. We do the FibroScans always in the fasting condition. What we did check several years ago was just in those that was in healthy controls, what the difference was. And you have a small difference of 1 to up to 3 maximum kilopascals. But it might be indeed that this might be more pronounced in this population due to the sinusoidal alterations. Yeah, it's absolutely, we didn't investigate it, but it's an excellent idea. As Jörn said, we're absolutely struggling with how we can have, let's say, quite accessible, safe, easy tools to measure something like that, because we did it with HVPG measurements, and that's all very nice, but that's not something you can apply to routine clinical practice. It helps us generating these data and it advances the research, but it's not something you can do later on in routine clinical practice, that's for sure. No, it's an excellent idea. Thanks.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingnash.com. We'll be back next week with our first round of individual interviews, and we'll announce our subjects and topics early in the week. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.